Talks. My name is Ray Dorsey. I'm delighted to be here with Susan Dentzer. Susan is one of the country's leading thinkers on health and health policy. For 10 years, she was the on-air health correspondent and head of the health policy unit for the PBS NewsHour. She has a professional backdrop, as you can see. She then served as the editor-in-chief of Health Affairs, the world's leading health policy journal. She's an elected member, and I don't think there are many people who can claim this, of both the National Academy of Medicine and the Council on Foreign Relations. She's the former president and CEO of the Network for Excellence in Health Innovation, and is now a senior policy fellow at Duke University's Robert J. Margolis Center for Health Policy. Today, she spends her lunch hour with us. Susan, thanks very much for joining us.
Great to be with you, Ray. Thanks so much for having me.
So in addition to being the season of COVID, it's also graduation season. A younger Susan Dentzer, I learned recently, was among the first women to ever attend Dartmouth College, first to graduate, and I think the first female chair of the Board of Trustees. Can you tell us a little bit about your experience?
Sure. I was actually in the second fully co-educated class at Dartmouth. The first four-year graduates showed up the year before I did. I arrived in September of 1973. And there were about 500 women on campus at the time out of a student body of around 4,000. So we were still fairly rare animals, even in that second year. It was a great experience looking back. It was not without a lot of rockiness along the way. We obviously arrived on campus where at least half of the students had come there thinking it was an all-male school, and then found out, midway through their Dartmouth careers that it wasn't going to be that way. And that sat really well with some people and not so well with others, and it still did not sit that well with many alumni. So there was a lot of sort of anti-co-ed sentiment to deal with for a couple of years. I have to say, once those students graduated and everybody there came knowing it was going to be a co-ed school, the atmosphere really, really changed. And now when I go back, I just see, nobody even remembers a time where there weren't women at Dartmouth. It's a really exciting thing to see now.
So was Dartmouth behind other Ivy League colleges in terms of becoming co-education?
In the last wave, it was Dartmouth. A lot of the schools had companion female schools. Harvard had always had Radcliffe. Of course, Columbia had always had Barnard, and those kind of sort of merged for a while and then essentially more or less disappeared as freestanding entities. So all of this was kind of happening in the Ivies over a staggered period of time. And Dartmouth was kind of at the end. There had not been a companion female school to Dartmouth, so it was a big change. I think the trustees voted in early 1972, or it might have been late 71, to go co-ed, and then the change began.
Can you tell us a little bit about the animosity?
Yeah, it was, I have to say, with the perspective of years, I see this was not unique to Dartmouth, by any of this. But, sort of a fair amount of animal house behavior was widely tolerated. I think, it was not unusual to be serenaded by a bunch of drunk guys outside your room singing a semi-profane song in the wee hours of the morning. I remember I had one professor, I took a classics course at one point, and we were reading the Iliad, and there's an episode of the Iliad where Hera, the wife of Zeus, decides to seduce her husband in order to get him to do something that she wants him to do, involving her beloved Achilles. And I was one of two women in this class of about 60 guys. And the professor turned to me and said, Miss Dentzer, could you give us the female point of view on this episode of the Iliad where this woman, this Greek goddess, is seducing her husband? And that's sort of what you were led to expect, that there was going to be a female point of view. You were going to be the representative of it. So there are always these sort of overt and also subtle ways, people were transitioning to the new world, and it wasn't always easy.
Do you remember your first day?
I don't remember my literal first day. I remember my first month, September, and the weather was gorgeous, and you had that sense. I've always had that special memory of a little bit of frost in the air. The sky is blue. Everybody's coming back on campus. You're enrolling in new courses. You're meeting new people for the first time. It was really, really special. And then 4 years later, as I was a senior, I was an English major. I've written about this subsequently, So how bad is this? You're having your senior seminar on the poetry of Robert Frost. You're having your meeting on the farm of your Dartmouth professor, which happens to be a stone's throw from where Robert Frost farmed years before. You're drinking wine and cheese because, of course, in those days, the drinking age was 18, so everybody could drink, and professors served you wine and cheese for your seminars. And it's a beautiful September day, and you're having this deep, deep conversation about the meaning of some of these really extraordinary poems. By the way, Robert Frost is one of the most famous dropouts ever in Dartmouth history because he came and was on campus for about 6 weeks and then he left. So just sort of all of these threads coming together, how bad was all of that? It was pretty special.
Any really bad experiences?
Yeah, I think the ones I described, I remember being in one fraternity basement one night when a very drunk member of the hockey team came up and poured 2 beers on my head, deciding that I needed to be baptized, at that point, and by the way, years later, profusely apologized to me after he had undergone a serious alcohol rehabilitation program, right? Okay, so that tells you a lot. And again, now I understand this was not unique to Dartmouth. Look at what's happening today. Look at the hazing that is still going on in campuses across the country. Look at the deaths still arising out of alcohol abuse and hazing. So it wasn't unique. It was part of the fabric of the time, and unfortunately probably still persists on a lot of campuses today. And alcohol use on campus, obviously, it's not an issue we're spending a lot of focus on at the moment amid COVID, but we know it's still real.
We'll get to healthcare in a second. Anything you'd have done differently?
Yeah, I would have gone down more roads. Everybody probably thinks they know the famous Robert Frost poem, "The Road Less Traveled." 2 roads diverged in a yellow wood, blah, 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 blah. And everybody just quotes the last 2 lines, which is, I took the one less traveled by, and that has made all the difference. And it's sort of a paean to, I did it my way kind of thing. If you read the poem, it's very clear that the roads looked exactly the same, and one road was not less traveled than the other. So the narrator of the poem is basically looking back in time and completely screwing up his memories because the roads look the same. And in effect, what Frost is saying, more or less, is the roads you go down in life and the roads you don't go down in life can equally influence you. It's the roads you don't go down in life that often have as much impact on you as the roads you do go down. We tend to romanticize this when we look back on our lives and say, oh, I made this critical decision to go X. Well, typically, you're not making that decision that way. You're just kind of putting one step ahead of another. I look back on my Dartmouth career, I would have gone down more roads. I would have said, I don't know anything about this particular field. I'm here for 4 years. I should open myself up to it. I should do that at risk of failure. I should do that at the risk of, harming my GPA. It's not going to matter later on in my life what my college GPA was. I wish that I had fully understood that and had thrown myself into more challenging and different academic experiences.
My son just graduated college. I'm going to share your little excerpt there with him. So turning to healthcare, you wrote and edited this outstanding book called Healthcare Without Walls. As some of you guys saw on the promo, if you want a free copy of the book, all you need to do is pledge $25 to your local food bank and email us your name and mailing address, and we'll send you a copy. You can just email us at info@chet.rochester.edu. Again, Susan will send you a signed copy of her book. why did you write this book, Healthcare Without Walls?
Well, like a lot of people in healthcare, you develop a very firm grasp of the inadequacies of the whole sector. And one of the inadequacies, and frankly, opportunities for innovation that we identified was basically taking advantage of health information technology and also sort of just basic technologies like telehealth, and adopting those more quickly into healthcare. And as we know, healthcare has lagged on HIT, other sectors of the economy, by 20 or 30 years. Virtual care has, as Ray knows well, had relatively little take up. And you look at, I used to open some of my presentations by showing a slide from the Jetsons, this cartoon of the 1960s, where the animators were imagining how people would get healthcare in the future, and it's over a television screen. The doc is on a television screen, and the Jetsons are communicating with the doc that way. Well, that was 1962, and the reason was there were actually early examples of telehealth and telemedicine going on in the 60s. So you ask yourself, why 60 years later is there so little take-up of all of this, particularly when, as we said in the book, it's not that virtual is better. It's really just, when is it going to be better? Obviously, in a perfect world, we'll all have complete 100% access in person to loving, caring clinicians who will spend inordinate amounts of time with us, deeply understanding our needs. That's not going to happen, right? So
sometimes it does.
Sometimes it does. Not very routinely, right? And particularly if you think about, the whole concept of patient-centeredness, patients sometimes want to be much. You kind of want to get what you want out of it, and then you want to go on with the rest of your life. And so the combination of convenience, of difficulty with physical access, all of those things obviously could be dealt with very well through virtual. And what we particularly stressed is, if you take healthcare and divide it up into two very simple pots, there's a very simple dichotomy. There's the healthcare that necessitates laying on of hands. If I get into a terrible car accident, I'm not going to expect a telehealth visit with my trauma surgeon, right? I get that. There's a healthcare like that. And then there's the healthcare that is about exchanges of information. And a lot of healthcare is in that second bucket. So if exchanges of information can take place virtually in a way that is better than satisfactory, and that it is easier, more convenient, it transcends time and space, why doesn't the system do more of it, was really the question that we posed at the outset of the project. And as we went through the project, we found the simple answer to why is this not more adopted in healthcare was because it's healthcare. And then when you unpack that, it's payment. I'm not being paid to do it this way. It's regulation. The state won't let me do this across state lines without getting licensed in another state. It's human factors. I don't really know how to do a physical exam virtually, and I'm not really prepared to find that out. It's workforce. This is the way I've always done it. How can I move to a new way? And how do I redo my workflow and everything else to make this work? All of those factors stood in the way of moving to this, what we've described as the paradigm of healthcare without walls. And as we see now, in the case of the pandemic, a lot of that has been suspended. And when the payment restrictions go away and the regulatory restrictions go away and people can't physically go to healthcare facilities or don't want to, guess what happens? Healthcare without walls.
In the book, you ask the reader to imagine a healthcare system that comes to people, meeting them where they are in their homes, workplaces, or communities, rather than expecting people to always go to it. You then outline in your book, which you edited in 2018, 4 scenarios where such a system would work well. Can you read the last example on top of page 6?
Well, I'll just describe it briefly. It was in a way one of the hardest ones to get our work groups to focus on, because it seemed so out of the stretch of the imagination. But it was pandemic flu. It was, what if there is a flu pandemic that is about to hit, and we take into account everything we know about flu. So if it's a new strain of flu, we don't have a vaccine yet, right? And we may or may not have effective antivirals. So our main tool is going to be social distancing. So we have to put in place a social distancing paradigm. And we want people, if they're not too sick, we don't want them to come to the hospital. We want them to stay at home. But how, maybe we do have antivirals that we need to get to them. So how do we create a system where people are mainly staying at home, socially isolating, not going out, not going to sporting events, not going shopping, not going to malls? How do we do that? And the scenario that we created was, we're going to support people as much as possible in their home. We're going to conscript all the Uber and Lyft drivers in the country to start delivering medications and things and fever thermometers to people in their homes. We're going to do public service announcements and counseling of worried well people by platforms like Zoom into their homes to explain to them what needs to happen. We'll have telehealth visits as needed. And essentially what we'll do is get through the early phases of the pandemic through this combination of social isolation, supporting people who needed care in their homes, and dealing with the realities that we don't really want a whole lot of unnecessary traffic in healthcare systems at that time. That was the scenario that we created.
I'm going to read it.
Okay.
So, a city full of people frightened by an outbreak of pandemic influenza. People with flu symptoms could take self-administered tests for the flu virus, and if they tested positive, could have antiviral medicine delivered to their doorsteps. Mass online public health clinics would urge healthy people to stay at home until the epidemic ebbed. So you wrote this 2 years before COVID-19. We've yet to realize what you laid out before the fact. What made you think about this scenario in 2018, 2017?
Well, I think a lot of it, frankly, goes back to my earlier career as a journalist and having lived through a couple of the epidemics of the time. Some of them where we dodged the bullet. I mean, the anthrax attacks in 2001 turned out to be rather small scale in the end, but they were very, very deadly. And of course, we spent a number of years thinking that bioterrorism was around the corner, and there was a lot of pandemic planning that went on around that. Fast forward, SARS, same thing. We managed to contain the SARS outbreak, but a lot of the principles in the early days were going to be the same. It was going to be, we don't have a vaccine. We don't have much in the therapeutic arsenal. So we've got to do contact tracing. We've got to keep people socially isolated, et cetera, et cetera. And then we went through H1N1, of course, et cetera. So all of that was very real to me, that someday we're going to get another pandemic. And of course, the number one fear was that it was going to be a pandemic influenza. Here we are, right? And many of us who've covered these topics over the years, it's been very, very frustrating, because we know that locked up in many drawers around the country are pandemic flu plans that should have been pulled out of everybody's drawer at the end of December and weren't. And this, nobody adopted the Healthcare Without Walls pandemic plan that we could tell, but this should have been one of them. It should have been waiting to be pulled out of the drawer. And as we know now, if we had just undergone physical distancing, we probably should have done nationwide physical distancing the first week in February. But even we know from new analyses, even if we had just done it a week or two earlier, we would have saved almost 40,000 deaths. So if we had had this plan in place, we would have been in a lot better shape.
Why didn't we use these plans? Why didn't we use them?
Sorry, let me turn this
No
on.
worries.
This is, speaking of the devil, this is my parents in nursing home in New York calling with their daily report about the COVID infection. So forgive me.
No worries.
Yeah.
I hope your parents are well.
So far, so good.
So why we have these reports? Why didn't people use them? Why weren't they put into place?
Well, I think it's been fairly well documented, particularly with the change of the last administration. The people who came in to the National Security Council basically killed the pandemic flu operation that had been created there. People don't want to believe that this stuff is real. It does, and as I said, it was even hard for us to get people to focus on our pandemic flu scenario, because if you've never lived through even the inklings of a pandemic, you can't even get your mind around what could occur. None of us will ever have that problem again, right, after this. But I think there was just basic resistance to believing that this could happen, that the scale could be as devastating as it was, that it could happen as quickly as it did, and that the necessity of action and being able to spring into action by implementing plans that had already been drawn up was critical. And the people who were in charge, for better or worse, did not do that.
We're going to take questions from the participants. We have a record number of participants, over 100 participants on. Thank you very much. Please put your questions into the Q&A, and we'll put the email address to get a copy of the book. We'll put that in the chat right now, but do put your questions in. I'll go here next. For 20 years, you worked as a journalist. You were first worked for Newsweek magazine, then U.S. News and World Report, and then on the NewsHour with Jim Lehrer on PBS. I think some people are going, I know that person. I've seen her before, and the answer is you probably have. You touched a little bit about the present administration's approach to COVID. How about from a journalistic standpoint, how is COVID-19 being covered?
I think pretty well, to tell you the truth, by the real mainstream media. I think some of the reporting, in particular in the New York Times and the Washington Post, has been extraordinary. And some television has done a really good job. CNN has done, I think on balance, a fantastic job with its coverage. Is there more to be done? Yes. And I particularly am drawn to, we know now the broad outlines of the story, right? What we don't totally understand is a lot of the intricacies of what went wrong. Early on in the pandemic, I tweeted out, not that anybody listens to me, but I tweeted out, we're going to need a 9/11 commission style report on what happened during the pandemic. And I still believe that. I don't think it's going to happen under this Congress or this administration, but I hope if there's a new Congress and a new administration, they will impanel a COVID-19 commission report that will walk through these very critical days when we knew about what was happening in Wuhan. And even if we didn't have full access to all of the information, we had enough to act. And what were the choke points? What went wrong? Again, we know the outlines of it. We know that the CDC's initial attempt to create a diagnostic test screwed up. We know these things. I was a long message, obviously, from the nursing home. We know these things in outline, but we don't know the details. And we need to capture these learnings. Some people watching this probably read The Best and the Brightest, David Halberstam's phenomenal book about decision-making around the Vietnam War. And it just was a fabulous piece of journalism chronicling how some incredibly smart people could still make really flawed decisions. I'll leave to people on the webinar whether they think that people dealing these decisions were also incredibly smart. Whatever the case, things went wrong, and we need to understand that in detail and then create new models, new plans, new approaches for this. Because, if nature could inflict this on us several times in a relatively compressed period of time, I left out some of the in between epidemics, MERS, right? So we had SARS, we had MERS, we had H1N1, and now we have SARS-CoV-2. In evolutionary terms is the blink of an eye, right? Between 2003 and 2020, 17 years, blink of an eye in evolutionary terms, and we had these very, very deadly viruses emerge. It's going to happen again. And we don't even begin to understand the impact of climate change in all of this. But you have to believe that there is an impact of climate change. So we better darn well get ready, because we're going to see it again, certainly once, if not twice, before the end of our lifetimes.
Is this a story that you'd be, if you were a PBS NewsHour and you were preparing a segment on COVID, is this the story that you would be telling?
Well, it's hard to do this in television, to tell you the truth. One of the wonders and also limitations of television is you've got to have pictures, right? It's hard to go back in time and have a picture of decisions not being made, right, 2 months ago. So I think it's probably you're gonna read more of this in print journalism and books. I mean, I think some fabulous books are gonna come out of this whole experience. But television can bring people together. Obviously what the NewsHour particularly now is doing, because they can't get out and shoot, a lot of scenes in the field. They're basically just talking to people. And so, yeah, I think if I were back on the show, I'd be looking to pull together some of the most interesting people who have some knowledge about what went wrong, trying to tell this story to us in a way that is compelling. I think the public in general gets it. We understand that bad decisions were made and things weren't done and things went wrong, but we don't understand all of those details, and I think we need to.
We're going to take some questions in just a second. Before we do that, I'll talk a little bit about the future of healthcare. So healthcare has changed more in the last 2 decades than it has in the previous 2 generations. Despite often heroic efforts by physicians, hospitals, healthcare workers, medical centers across the country are losing millions of dollars. Healthcare workers are being laid off in record numbers. Furloughs are widespread. Unemployment is rising. Many are going to lose their health insurance. Some project that Medicaid enrollees will reach 90 million, and states are already financially strapped. What does the future hold for healthcare?
Good question, right? I mean, we're in deep, what. We don't know. We don't even know 2 months down the road what's going to happen. I mean, it's pretty clear there's going to need to be another major fiscal package that has a lot of money in it to go to hospitals, health systems, and everybody else, just even to get through the next several months. We cannot afford to have the system break down to the degree it has. I think at the same time, and Ray, you and I have talked about this, we know that this whole episode exposes some of the real weaknesses in the system. One of the major weaknesses still is the system runs on volume, fee-for-service care, and a lot of that is elective surgery. And by the way, it's better if the elective surgery is done in the commercial sector because people get paid more in that way. And if you've got a system that's heavily dependent on that, and that goes away in a pandemic, you don't have a financial base on running your system. Well, that's wrong. We know probably too much of that is getting done anyway. Not all of it. I mean, a lot of people are really happy they got knee replacement surgery, and that's good. A lot of people probably didn't need it. And we know we have we have waste in the system that is actually profitable for the system, but it's waste. And so, I guess the one glimmer of hope is that as we put Humpty Dumpty back together, let's not build back in the waste. Let's not build in the piece of the system that keeps it humming because we're doing too much stuff that doesn't help people and actually could be hurting people and costs a lot of money, by the way, as well. We got to work our way through this. We got to keep the system running over the next few months. And obviously, if we have a second wave of COVID in the fall, we desperately need it, the system to be intact. But then we got to figure out how to reinvent it. And that extends to the coverage issues, because You could say, looking back, one of the strengths, obviously the way most Americans get coverage, health insurance coverage, is through employment. That works really well in a full employment economy. It doesn't work really well right now. And going forward, we have to think really seriously about how if we're going to keep the employment-based system, we have got to create the safety net that is intact if this happens again. And so that there is a way that people can have coverage. And that means we're going to have to create a real parallel system. Maybe it's not Medicare for all, but maybe it's a Medicare buy-in. Maybe it's a Medicare buy-in at age 35 and not 55. We're going to have to create that because this doesn't work. And it won't be the last time that we confront this issue.
So again, the book is Healthcare Without Walls. The email to receive a copy is at info@chet.rochester.edu. We have lots of questions coming in. Stanley Lehman asked, do certain payment systems better align with Healthcare Without Walls?
Yes, they do. And we had a long chapter in the book basically laying out that case. Of course, for many years, the reason payers didn't want to pay for telehealth is, A, they thought it was inferior medicine. So they certainly didn't want to pay at parity with physical visits. And B, they were afraid that it would be abused. So that, if I knew I could get a telehealth visit with my doc, I'd spend every day of the week having a teledoc visit with my doc, and my doc would want to do the same thing. So there would be all this waste. That was the fear. In a fee-for-service system, that's not an unreasonable fear. If the doc has incentive to do this, and I don't bear particularly any costs, if I didn't have a particularly large copay, of course utilization would explode. So what you want to do is create something that is more like either a bundle or global payment, so that if it's appropriate to do telehealth, you do telehealth, but you don't do it to excess, and you don't use it when it's not appropriate, because you're being paid under a bundle, and particularly a capitated type arrangement or you're being paid on the basis of outcomes. So if, Ray, to take your line of work, if you're paid on the basis of how well your Parkinson's patients do, not how many visits you give them, then you will make the wise decision about what kind of visits they really need to get to the best outcomes. And that's the kind of a payment mechanism that really needs to be in place to make really judicious decisions about when to do virtual, when not to do virtual, and how do we put together the care package that gets to the best outcomes for patients.
We've got a lot of questions, so we're going to make you go shorter, Ms. Dentzer. Dr. Lauren Bruckner, a great colleague, asks, what do you feel will be the biggest barriers post-COVID for continuing to move toward your vision of healthcare without walls, and what can be done to overcome these from those of us delivering care?
Well, to just build on what I just said, if we don't have payment mechanisms in place that basically drive the whole system to better outcomes for patients, and that is the basis on which systems are paid, then the fear is going to be, if we go back to fee-for-service land, then there's going to be an explosion of utilization from telehealth, and we can't afford that. So I think a real barrier will be, are we not moving now more quickly to different payment structures for health systems? We know that technology is not the rate limiting factor. It never was. It turns out that you can teach old dogs new tricks real fast, right? So it's going to be, I think that the big obstacle is going to be arriving at the right set of payment that really enables this to move forward in a way that's good for the system and good for patients.
Dr. Adam Dicker from Thomas Jefferson, regular listener, asks, based on your experiences, Susan, what changes would you like to see implemented in undergraduate medical education and graduate medical education?
Talk about a need for innovation. I served on the Geisel School of Medicine at Dartmouth, the Board of Overseers, for I think total of 26 years. And over the 26 years, there were only 1.5 curriculum changes over the entire period. It takes a long time. It's a real as we know, a kind of a Soviet-style system of medical education in the sense of curriculum innovation and reform. And I think we need some real curriculum innovation and reform. For a long time, I've thought, does medical school really need to be 4 years? It's not clear to me it does. As we know, a lot of medical schools now are moving to have people earlier in clinical rotations. That's good. I don't see why you shouldn't have a clinical rotation on day one of medical school, at least to some degree. This whole, and then sort of compressing the timeline, getting people out into the field faster, and basically, training people on a world where EHRs, the information world is going to continue to change on people, and artificial intelligence coming in, and machine learning tools coming into healthcare and medicine, exposing people to all of that, having them design delivery, mini delivery reform projects themselves. I mean, I think that is really where a lot of the energy and curricular redesign needs to go. And I think it would be really exciting. We already know a lot of people have moved to the flipped classroom mode, where you get your lectures in basic science on tape or video or whatever, and then you go into the classroom and really work together in teams and innovate. That is the kind of energy that I think we need to have suffusing the whole undergraduate curriculum.
I don't know if you heard the 10,000 cheers from all the students going into their first year of medical school, including Abigail Arkey, when you said about shortening the duration of medical school and saving them some money. Dr. Bruce Leff, a great friend and colleague who created a hospital at home model over 20 years ago. He said we can provide hospital level care to older adults in their home. He did this in the 1990s. He asked you about this new stimulus package or recovery package. Should that package go to support the current model of care, or help a transition to a new model?
I think it's a really important question, and actually at the Duke Margolis Center, we've already started to think, is it too early to tie the next package to a bunch of strings for institutions? It might be, but if there's a package after this, it won't be too late. It's time to really tie funding, supportive funding, to system transformation along the lines I described earlier. I don't know if the world is ready for full capitation, but the sooner we move more along those lines, where institutions and people are taking on appropriate levels of risk. I don't know how fast this can happen right now. I mean, nobody's going to sign up to take risk in the current environment, right? But we have to start to think about that, creating that capability system-wide, because we can't afford to put back what we had before. And hospital home is a case in point. Bruce, I think Bruce and I have talked about this, but you have to look at hospital home and say, why isn't hospital at home 20 or 30% of hospitalization in America? You can't explain it except for all of the forces of inertia that we described earlier. So creating the payment and other structure and insisting on this move is going to be critical. I think the real issue now is the timing of it. When do you start to hold systems accountable for this, given that things are in such a dire situation at the moment?
Given that medical centers aren't going to be eager to take on risk, and quite frankly may not be able to take on financial risk, can we do this by changing the fees that we pay for services? Can we get rid of facility fees? Can we direct facility fees to enable hospital at home type models?
We have to, right? We have to. And we have to think, there's nothing new under the sun. I will say that back in the late 90s, early 2000s, then Senator Daniel Patrick Moynihan was talking about how we needed an academic medical center trust fund to support academic medical centers. I don't know whether we'll pull off a trust fund, but thinking about, so we know we need academic medical centers. How are we going to fund those? Are we going to fund them by the fiction that the joint replacement that they do, or the baby that they deliver, is so much better than the babies delivered elsewhere that they should charge 5 times what community hospitals do, and that's how we support them. It doesn't make any sense, but we need them, right? So what does that mean? Does that mean we have to go back into regional health system planning, where we decide, yes, we need academic medical centers, here's where we need them, and here's what they should do, and here's what they should give up and not do? Who knows? It does seem to me like we need to start putting those concepts on the table, and then dedicated sources of funding to keep these institutions alive, because we do need them. But the way we have been funding this through a whole bunch of cross subsidies, I think it's not sustainable.
Great. Dr. Ira Schulson asks, what do you see as clinical and health research opportunities for healthcare without walls?
Oh my God, how much time do we have?
you get 30 seconds because we have a lot of questions.
There are quite a lot, because now we have real, it's not theoretical anymore, right? We've got things that we can study. We can study expansion of, hospital at home in COVID should have been a reality. Now, we probably couldn't have pulled it up because we had shortages of PPE, among other things, right? Not to mention staff, right? But we know there were a lot of cases of COVID where people did not have to have ICU level care. They had floor level care. Could we have had a hospital at home system in place? Somebody's going to start doing this and setting it up, as they have now moved massively to telehealth. Looking for those opportunities of things that are happening now that are different, and then studying them, I think is just an enormous opportunity for the field.
Harry Gawanter asks, what administrative waste would you eliminate, and what would you start with first?
God. Well, as we know, a lot of the waste is tied up in the payment system. We know this. We know that the billing. I think here's a study. I'm not sure anybody on this webinar is going to want to do, but how many billing people got let go from health systems in the COVID period? I bet you none, right? I bet you janitors and maintenance and housekeeping people were let go before the billing people were let go, right? That tells you how crazy the system is. As we know, most big hospitals and health systems have more numbers of personnel involved in the payment and billing apparatus than they have beds, right? That's crazy. We have got to streamline payment, and I think the simultaneous opportunities of moving to more global payments, global budgets, less just craziness in the payment, that's the easy place to start. And that's not going to have a direct effect on clinical care. It's just going to take a lot of the waste out of the system from that perspective. And then with logical payment approaches, then we can start to drive out unnecessary care, wasteful care, et cetera, et cetera.
More billing specialists than beds, more layoffs for nurses than billing administrators.
I bet. I don't know this, but it would be a hypothesis worth finding out about.
Isaac Rodriguez Chavez asks about clinical research, which is governed by the Code of Federal Regulations that applies to shipping investigational medical products nationwide. Why do you say that physicians must be licensed in each state to ship and administer investigational medical products across state?
I don't think I said that. What I was talking about was the direct delivery, for example, of telehealth, where, as we know, in most states, you have to be licensed in the state in which the patient is receiving care in order to provide telehealth across state lines. And there's a physician compact, about half the states are in it, which basically slightly expedites the process of getting a license in another state once you've been licensed in the original state. But what sense does that make? Why don't we have national licensure for physicians? Part of the reason is because the states collect a lot of fees from people being licensed in every state, right? And the state medical boards want to perpetuate their existence. No offense to anybody who's on a state medical licensing board, But does this make any sense in the current environment? No. I will probably be dead before there is a national licensure system, but there should be.
And so there is one for the VA, for example. So if you're licensed to provide care to any veteran in any state, you can do so nationally. So there are models.
VA is exempt from this. Yeah, VA is exempt from that. And if VA is exempt from that, why shouldn't everybody be?
Why not Medicare, for example, as a next step? Howard Rice asked, how now that patients have experienced telehealth, will they expect that this will be part of their practice of medicine as we slowly return to the new normal? He's the CEO of Teledentist.
I believe so. I believe so. I think just the way a lot of clinicians have done their first telehealth visits in the last couple of months, a lot of patients have had their first telehealth visits in the last couple of months and found them very satisfactory.
We'll try to get a couple quick questions in here and then we'll have you wrap up. Dennis Mulder asks, Susan, what is the potential of care without walls in the mental health space?
Enormous, enormous. And some of the most interesting apps, for example, out there are in the mental health sphere. Just one quick example of an app called Focus, which basically is kind of a behavioral therapy intervention for people with serious and persistent mental illness, where you can actually walk somebody through on a phone, not even you load this onto your phone. And so if you're a patient who's having hearing voices, you can walk through this dialogue with your clinician, in effect, asking you, well, remember we've talked about this in the past. Remember how voices don't always tell you the truth, and you can go outside and look at cars coming down and try to tell us what the voices tell you those next cars are going to be in terms of color, and then see if it really works that way. These are really innovative things where you are engaging a patient just the way you would engage a patient in a physical visit, but doing it remotely and virtually, and it's very exciting stuff.
We have the last question to Carrie Burtnight, an outstanding gerontologist. She asked to make healthcare without borders accessible to geriatric patients, especially the oldest old. What tech solutions do you recommend?
A lot of effort has to be put into making any technology as user-friendly as possible and as simple as possible. And we know that's happened. There are smartphones now designed specifically for use by older individuals. The early feedback that I'm hearing is that the bigger issue has not been age, it's been socioeconomic status. So if you're an older person and you have a really smart grandchild who can set you up to do your Skype visit, you don't have a problem. It's if you aren't socioeconomically well off enough to have that capability, or have your grandchild have that capability, that's where the rub is coming in. It's been more of a socioeconomic issue than an age-related issue. Nonetheless, as I say, I do think we've got to be really attentive to user-friendly design of any of these technology-based interventions, and probably create new people in the system who are in charge of smoothing the way on technology, particularly for geriatric patients.
My apologies to all the people we didn't get to your questions to today. Susan, as you alluded to early on, you like poetry, and you said that poetry speaks an important truth, and that human beings like us have been down similar roads and in similar situations before that shattered the senses. COVID-19 has shattered our senses. Do you have a poem that speaks to you now?
I do. I'll just read one that speaks to me on the sort of the negative side, and then I'll read a little bit one that speaks to me on a more hopeful side. So this is a poem. Anybody who loves poems, you've probably spent a lot of time, as I do, on the Poetry Foundation website. And this is a poem I came across a couple of months ago. It actually was written in 2008, but listen to how prescient it is. It's called Hospital Parking Lot in April. Once there was a woman who laughed for years uncontrollably after a stroke. Once there was a child who woke after surgery to find his parents were imposters. These seagulls above the parking lot today, made of hurricane and ether, they have flown directly out of the brain, wearing little blue-gray masks, like strangers' faces, full of winged mania, like television in waiting rooms, entertainment, pain, the rage of fruit trees in April, and your car, which I parked in a shadow before you died, decorated now with feathers, and unrecognizable with the windows unrolled and the headlights on and the engine still running in the parking space of the sun. April, hospital parking lots in April, and death, right? That sort of captured this experience for me. On the
hopeful one.
Robert Frost's wonderful poem, Directive, which is too long for me to read, but is worth digging up. And the last 2 lines of it are, here are our waters and our watering place. Drink and be whole again beyond confusion. And I hang on to those last words because I believe that's where we are right now. We need to drink, not booze, drink of the waters of life and be whole again beyond the confusion of what we are living through. And the fact that Frost wrote that poem so many years ago tells you human beings have been down these roads before. We have all needed to drink and be whole again beyond confusion, and we need that now.
Well, you've given us clarity, and I wish you and your family to be whole again, and all of our listeners. Susan, thank you very much for joining us on today on a very moving and enlightening Chet Talk.
Pleasure, right?
Our next Chet Talk, we go under the dashboard. Next Thursday at May 28th at noon Eastern, we'll be speaking with Derek Bowen, the Vice President of Business Development and Strategy for Blackfin. Blackfin takes multimodal data from genetics, from imaging, from clinical, from biological, from research studies, and makes it visual. If you want to see what we've been missing in clinical trials, join us next Thursday. Until then, the Center for Health and Technology at the University of Rochester thanks you for joining us on Chet Talks. Thank you again, Susan.
Thanks, Ray. Take care.